Thank you, Chairman Schuler and Ranking Member Lukemeyer, members of the committee. As said, my name is Wayne Stanfield, and I'm President and CEO of the National Association of Independent Medical Equipment Suppliers, or NAMES. Working in medical equipment is a second career for me. I'm a retired Air Force and spent 20 years in the air traffic control business. NAMES is a trade association representing and supporting independent DME suppliers. I also am a partner in an independent DME supply company, Carolina Med Plus, in the Concord area and Round 1 Charlotte CBA. We participated in the bid, but did not win a contract because we bid above the pivotal bid. NAMES commends the subcommittee for examining the impact of CMS's competitive bidding for DME on small suppliers, which will be profound. Competitive bidding for DME was a part of the MMA 03, and while the stated purpose was to save Medicare money, that contention gave no consideration to the service to patients and the impact on small businesses, communities, and employment. CMS contends that DME competitive bidding represents market-based efficiencies. I respectfully submit that this program does not represent anything close to healthy market economics. I also note that CMS has ample authority to lower fees without applying competitive bidding. Competitive bidding makes perfect sense for a multi-million-dollar aerial tanker to replace the aging KC-135, but makes no sense for an $89 walker or for oxygen services to a senior citizen. Competitive bidding has no place in health care and will result in higher costs to Medicare, lower quality, and less access to needed services. Competitive bidding in itself is an exclusionary process. It's important to understand the gravity of this assault on small business. Since the vast majority of HME providers are small, independently owned businesses, it stands to reason that they will bear the brunt of the effects of competitive bidding. According to CMS figures in 2007, there were 110,272 supplier numbers billing Medicare, and of those, 103,227 bill Medicare less than $300,000 per year. That's 94% of the total supplier community. It also is important to note that despite new startup businesses in the DME industry, there was a decrease of more than 4,000 suppliers from 2006 to 2007. Also notable is that the canceled first round winning bids in the 10 MSAs represented less than 10% of the total active suppliers, meaning 90% were excluded from the market. These small businesses are a major part of the engine of the American free enterprise system. They employ more than 1.5 million people while serving over 50 million Medicare, Medicaid, and private insurance beneficiaries. These businesses help keep patients out of institutional settings and at home where they prefer to be, but it's also the least expensive alternative. The DME segment of Medicare is historically less than 2% of the total Medicare budget, and in spite of the growth in the Medicare population, this has been virtually flat in growth in expenditures for decades. Yet this smaller segment of Medicare expenditures is repeatedly singled out for fee cuts, competitive bidding, and other measures such as the surety bond, all of which are forcing businesses to close and to stop serving Medicare patients. Home care and DME should be growing since the cost of this care is infinitely less expensive than hospital and nursing home. According to a recent market survey by the Fredonia Group, the need for medical equipment will grow by 5.5% through 2012, primarily due to the increasing number of older Americans. A program that reduces suppliers at a time when demand is increasing simply defies logic. This government-sponsored program will eliminate competition by dismantling a national network of suppliers that have reliably serviced the home health needs of Medicare patients for decades. While CMS has developed this program and has released the final routes for its implementation, it is Congress that authorized CMS to pursue this unworkable program. It is inconceivable that our government would promote a scheme to concentrate market share, eliminate competition at such a crucial time in our economy as we are at this present time. This is a formula for higher prices over time and is bad public policy that must be ended. NAMES strongly opposes the reimplementation of this flawed program and recommends that Congress repeal the applicable portions of the MMA03. Much of the anticipated savings has already been realized through previous cuts, such as the FEHBP cuts in 2007, elimination of the CPI for the DME industry for more than 5 years, and the devastating 9.5% cut to fees that went into effect on January 1st. I urge the subcommittee to support repeal of competitive bidding and return the free enterprise system to the small, independently owned DME providers and allow them to meet the needs of America's aging population. Thank you, Chairman Schuler.